So I'll be talking today on understanding ocular hypertension, normal tension glaucoma, and primary open-angle glaucoma. I don't have any financial interest. So as we all know, primary open-angle glaucoma is an optic neuropathy which is characterized by progressive injury with loss of the neuroretinal rim, which is manifested in the form of specific cupping on the optic disc and associated with a visual field defect with typical patterns which progresses in a typical way over a period of time and can be quantized by the quantitative assessment of the retinal nerve fiber layer on imaging studies. So in primary open-angle glaucoma, the major seat of the pathology is at the angle of the anterior chamber, where in the trabecular meshwork, whether due to old age or due to genetic factors, there are fusion and widening of the trabecular beams, and there is a extracellular proteoglycan matrix laydown which decreases the outflow and thereby causes a rise in the intraocular pressure. And this in turn causes a damage to the optic nerve. In normal tension glaucoma, there are various pathologies which have been hypothesized, one of them being the abnormal laminar structure, where the collagen is genetically modified to be less resilient to the IOP, and along with it, there are evidences of poor blood supply at the optic nerve head, which results in the cupping. So basically, in normal healthy conditions, there is a retrograde flow of neurotrophic factors which help in the RGC cell survival, where mechanical pressure at the lamina cribrosa or due to ischemia or other genetic factors, there is an obstruction of the exoplasmic flow which happens retrograde, and there is a glial cell activation and excessive calcium influx into the cell causing RGC death. This is also in a progressive stage where the neighbor-kill effect manifests itself. In the glaucoma continuum, if we look, the ocular hypertensives are mostly towards the left side of the spectrum, and the primary open-angle glaucoma and the NTG patients are mostly on the right side of the spectrum. Glaucoma is a slowly progressive disease with an average of 15 years taken to progress from early to end stage with the IOP of 21 to 25, with about 7 years from 25 to 30 and 3 years more than 30. So if you look at the general population, the ocular hypertension population is a subset of the general population, on which a subset is the group of people who suffer from primary open-angle glaucoma, and the normal tension glaucoma are a subset of the general population without a high IOP. So if we measure the intraocular pressure and compare it to the relative risk of primary open-angle glaucoma, OHT patients would lie somewhere around here in the curve. And if we look at the skewed distribution of IOP and the visual field loss, the ocular hypertensives would lie somewhere around here. So most of our information from the ocular hypertension group of patients is from the OHTS, which had a medication and observation group, and they showed conclusively that by 5 years in the medication group, the number of people progressing to primary open-angle glaucoma were almost half of those who were not treated. So what was the take-home message? It was this, that all ocular hypertensive patients do not require treatment, only patients with higher IOPs, above 26 millimeters of mercury, that is beyond 2 standard deviations of the high limit of the normal, the thin corneas less than 550 microns with large vertical greater than 0.7 CDRs and high PSD in the initial visual fields are the patients who benefit from treatment. Coming to normal tension glaucoma, it is the optic neuropathy of unknown etiology, which is characterized by cupping of the disc and typical visual field loss, but with a normal intraocular pressure. And it is a diagnosis of exclusion, and an extensive differential must be considered before diagnosing this. Like, for example, it's most important to rule out ocular hypertension. It is described to be of two types: the non-progressive variety, which may be due to a single event of systemic hypertension in the past, or it may be a progressive variety with chronic vascular insufficiency. They are typically described to have larger discs, peripapillary atrophy, particularly beta zones, and thin disc rims, shows more notching and more evidences of sloping of the cup and disc hemorrhages. The visual fields are focal, closer to fixation, within 5 degrees deeper, and dense paracentral scotomas may be presenting factors. So between the normal tension glaucoma and the primary open angle glaucoma overlap, the difference appears not to be intraocular pressure, but the disc resistance, which is supported by findings of abnormal laminar structure in NTG eyes with more susceptibility to damage at IOP at the normal range. And also it is quantified by the beneficial response to IOP lowering in a large subset of NTG patients in the CNTGS. The central corneal thickness is found to be significantly reduced in many eyes with NTG, where it's a risk factor for progression of disc and visual fields, and it may also represent the inherent structural abnormality of the supportive collagen in the lamina cribrosa, causing damage even at normal IOP levels. The mean arterial blood pressure minus the IOP gives us the ocular perfusion pressure because it quantizes the forces at play on the optic nerve. And if we look at the diastolic perfusion pressure, then as the diastolic perfusion pressure falls, prevalence of POAG increases. So there are associated conditions with normal tension glaucoma, like migraine, Raynaud's phenomena, and other vascular predispositions. Grants et al. Had shown the response of the nail fold capillaries to cold leaf measure may give us a clue. Some patients who are on hypertensive medications may experience excessive fall in systolic and diastolic blood pressures while asleep, and when the IOP rises in these conditions, the ocular nerve suffers from anoxia. It has also been seen that in asymmetric NTG, there are evidences of patients who have greater than 50% lumen reduction of the common carotid artery, and the ophthalmic artery, being the end artery, suffers from anoxia. In these cases, reduction of IOP by greater than 25% and reversing vasospasm is a goal. We also should think about the fact that up to 50% of patients of normal tension glaucoma have been described to be having obstructive sleep apnea, which also plays a role in the anoxia of the optic nerve here. Finally, coming to the collaborative normal tension glaucoma study, it showed quite conclusively that visual fields in normal tension glaucoma are very variable. But however, lowering the IOP by greater than 30% slows down the visual loss. But it is important to note that not all untreated patients progressed, but if they're untreated, about half progress by about 5 to 7 years' time. This would all in all perhaps summarize the phenomena of normal tension glaucoma.